Hello, everyone. My name is Max Cohen. I am a family physician and an athletic trainer, and I'm going to be helping to deliver the general medical content for this course and the knowledge needed to be an athletic trainer. I thought I'd start with vital signs as a good starting point here, as subject that I think a lot of athletic trainers maybe feel a bit uncomfortable with. I feel like a lot of athletic trainers don't often assess vital signs, and I wonder if part of that is sometimes because um, they assume that they're normal or that they wouldn't know exactly how abnormal values would change their management. So I'm hoping that today will give you some of the knowledge and tools needed to feel more confident with that. This will be combined with an in-person portion in a few weeks. This will be the sort of the pre-course prep for that course. And then you'll also be seeing some special topics that will just have video content that will also be posted as well. So let's get started with vital signs are the quantifiable measurements of the basic bodily functions. This typically includes body temperature, respiratory rate, heart rate, and blood pressure, although oftentimes pulse oximetry will be grouped into that. And then in the office setting, we are typically also assessing weight and pain. With the rest of the vital signs, I put asterisks here because they don't necessarily fit as much. With pulse oximetry, we'll talk a little bit about today, but not so much the weight and the pain, which is more of a subjective measurement. And we'll talk about the importance of objective measurements right here. So the senses using touch and sight and hearing and smell, we can collect objective data. And we can use different tools to measure and record that objective data. These then can give us clues to maybe our differential diagnosis or what pathophysiology might be going on. And I think it can also help guide the urgency and the tempo of how we go through our diagnostic and treatment plan. For example, when you see this patient at the bottom here in a tripod positioning, for example, perhaps they have a bad asthma exacerbation and they're really working hard to breathe. You assess their O2 and you note that it's actually below 90%. That might be somebody who you're more worried about than somebody who has normal vital signs and is experiencing a similar dyspneic episode. For body temperature, you may have all used a thermometer before, checking in Fahrenheit or Celsius, typical normal range from 97.8 to 99. And this can vary with assigned sex, different phases of the menstrual cycle, physical activity, eating, drinking. It can vary through the time of the day, as you see in the picture on the bottom right there. We're typically assessing this with an oral thermometer, although you may have learned about rectal temperatures being particularly important when of high consequence, like assessing for heat stroke. You might want to use a more accurate form of core temperature assessment. Fun fact, the pulmonary artery might be the best place to get a accurate core temp assessment, but as you can imagine, a bit impractical in the athletic training room. And so rectal is sort of a good surrogate. Tympanic temperatures using the eardrum are fairly accurate, axillary under the armpit, and then the surface temperature of the skin with those thermometers that you sort of drag across the forehead are all reasonable options, but we'll typically see oral used in most of our settings. Low temperature, as the American Academy of Family Physicians says, about 95 is our cutoff, where we'd start considering hypothermia below that. And one of the most common examples is environmental. Folks who maybe are not appropriately layered in the very cold environment. Um, and we may also see other things like metabolic issues, things like hypothyroidism, different medications, abnormalities in the central nervous system, sepsis, or an overwhelming bloodstream infection that, particularly in newborns and infants, you might see low temperatures as opposed to fever in response to a bad infection. And then on the other end of the spectrum, you have high temperatures, typically considering fever over 100.4 Fahrenheit. And again, you might see environmental causes for this in very hot, humid environments. When you're suspecting heat illness, this is where you might check that rectal temperature, find it to be over 104, and that's a patient who needs immediate cooling and transport to the emergency department. Sort of for further management there for heat stroke, which can be very dangerous. But some other reasons for elevated temperature, metabolic concerns as well, with perhaps thyroid abnormalities, different drugs, medications that can increase temperature, like stimulant medications, infection, malignancy or cancer can elevate the temperature, and then thromboembolic disease, things like DVT or pulmonary embolism, can also elevate temperature. For respiratory rate, we're typically assessing the amount of chest rise and fall cycles over a single minute. And so you're looking for somewhere around 12 to 20 in an adult. In children, it may be more, and you can use tables that you can easily Google online to find the correct vital signs, because it can be hard to remember for all of the younger age groups if you're taking care of younger athletes. In doing this assessment, if it's a regular respiratory rate, you may think about counting over 30 seconds, multiplying by 2, or even counting over 15 seconds and multiplying by 4. But you got to think about, I guess, the regularity, how important an accurate measurement is, and how quickly do I need that information. It can also be helpful in this situation to note the respiratory effort. Normal respiration is effortless, it's quiet. And so somebody who's very noisy or very strained, very working really hard to breathe, that's all important to know. A low respiratory rate, or bradypnea, is less than 12 respirations per minute. That can be seen with bad head injuries, different metabolic abnormalities, and certain drugs, medications, things like opioid medications can slow the breathing rate. High respiratory rate, or tachypnea, is considered over 20 respirations in a minute. And folks who are having overwhelming bloodstream infection like sepsis, you may see this, different metabolic conditions, different medications, allergic reactions or anaphylaxis can increase the respiratory rate. A primary issue with the lungs, either an obstructive process like asthma, COPD, or sometimes a process like pneumonia or pleural effusion, where you have fluid and it's making it hard to get oxygen across the membranes in the lung. This might make somebody have to breathe faster to be able to get that oxygen up in the blood. And then you have thromboembolic disease, again, things like pulmonary embolism, and other psychogenic causes like anxiety or panic can also increase the respiratory rate. For heart rate, we're typically counting the expansion and the contraction of the artery palpated at a superficial location over a minute. A normal range is between 60 to 100 for most adults, and again, with children, they may have higher ranges on that spectrum, so referencing a table as needed. You can again count over 30 seconds, multiplied by 2 if it's a regular heart rate, and it can be helpful to note the rhythm and the strength of the pulse at this point. So you're noting, is this a weak, thready pulse? Is this a bounding or strong pulse? Is this coming at a regular interval, or is it coming at irregular intervals? The most common place where we're checking this is the radial artery, which you can see in the picture here. Most of you probably have a lot of experience with this, and you may have practiced checking a carotid artery pulse in basic life support, emergency scenarios. In infants, you might use a brachial artery. Sometimes you'll check a femoral or a popliteal pulse, depending on the context of what information you're trying to get. And then I put here the dorsalis pedis or the posterior tibial as examples of lower extremity distal pulses that are important to check, for example, in a femur fracture to see if there's any distal vascular compromise. A low heart rate or bradycardia is less than 60 beats per minute, and that can happen in the setting of electrolyte abnormalities, heart disease or conduction abnormalities, primary issues with the heart that affect the electrical flow through the channels in the heart, metabolic issues, different medications like beta blockers that are geared to slow heart rate. And then highly trained athletes may also have slow heart rate as a normal physiologic pattern. High heart rates or tachycardia would be considered heart rates greater than 100 beats per minute. And you may see that in infections and sepsis, metabolic abnormalities, drugs, things like stimulant medications that can increase heart rate. Exercise can certainly and ideally increase heart rate in a physiologically appropriate way. And then thromboembolic disease, again, things like pulmonary embolism and anemia or low blood volume, dehydration, things that are causing you to have to beat the heart faster to maintain a appropriate cardiac output. Blood pressure measures how much pressure is in the artery during ventricular contraction or systole over the pressure in the artery during ventricular relaxation or filling, or what we call diastole. Normal range is somewhere from 100 to 120 systolic, over 70 to 80 diastolic in adults, and this is measured in millimeters of mercury on a sphygmomanometer. You're probably all familiar with the old mercury columns that as you pump and have increased pressure, the column goes up. We've maintained that convention, although most offices and blood pressure cuffs nowadays are not using mercury. The most typical cuff we're going to see is the upper arm cuff, but you can also see a wrist cuff, thigh cuff. There's plenty of other options. This is the most common. And I wanted to leave a couple of American Heart Association recommendations here for getting an accurate measurement, making sure that there hasn't been any recent smoking or coffee within, say, an hour, half hour before the measurement, making sure the patient has an empty bladder, that they've relaxed for a few minutes, they feel supported with their back and the feet on the floor, arm is at heart level, and then taking multiple measurements at least a minute apart and averaging to try to get the most accurate measurement. Low blood pressure or hypotension, typically considered under 90 systolic, over 60 diastolic. Blood pressure will go down typically, not usually this low in pregnancy, but a physiologic state to be aware of. Metabolic syndromes, again, or abnormalities, different medications that are like antihypertensives, things that vasodilate, open up blood vessels, or things that slow heart rate. Heart failure, so having an ineffective pumping mechanism, pushing blood forward will make it hard to mount a sufficient blood pressure. Sepsis, or again, the overwhelming infection of the bloodstream causing capillary leaking and vasodilation. Arrhythmias, abnormal heart rates that make it hard for the heart to generate sufficient squeeze. And then low blood volume states like dehydration, anemia, blood loss can all decrease the blood pressure as well. As far as high blood pressure, somewhere in the 120 to 129 range, you would consider elevated blood pressure. And then at 130 systolic, over 80 diastolic is where you would call like stage 1 hypertension. And there's several stages and more complexity that's outside of the range of this talk here, but suffice it to say that primary or essential hypertension is kind of what we think of in folks who have cardiovascular risk factors, older age, smoking, high cholesterol, diabetes, obesity, and family history, whereas secondary hypertension or hypertension as a result of a different underlying condition is what I want you to kind of be thinking about more when you see a young, healthy athlete with no known medical problems, no family history, no cardiovascular risk factors, and thinking, gee, why might this person have high blood pressure? Could it be an underlying kidney disease, issues with the adrenal glands, things like Cushing's disease, metabolic issues like thyroid, concerns, or drugs like stimulant medications, or estrogen in a birth control hormonal contraceptive. Did the patient exercise recently? That can elevate blood pressure. Blood vessel abnormalities or congenital heart abnormalities that can increase blood pressure, which hopefully you would know about from your pre-participation exam, which we'll talk about in a future series. But this may be the first time that you're picking up on it, especially if you're taking care of younger athletes that may have, for example, coarctation of the aorta or narrowing of the major blood vessel coming through the trunk. Things to be thinking about. For pulse oximetry, we're usually using a pulse oximeter. Goes on the finger, and it's assessing the percent of oxygen saturation in the peripheral blood. Normal range usually over 95, 96 to about 100%. And this is a great non-invasive test. It shines different wavelengths of light through the fingernail bed, and deoxygenated and oxygenated hemoglobin are absorbing light at different wavelengths, so it's able to fairly closely estimate how much oxygen saturation there is in the blood within about 2%, especially when blood gas percent is very high in the blood. It's a lot less accurate at lower saturations, which is just important to think about. But if somebody has saturations that are that low, you will probably also want to be thinking about expediting higher levels of medical care. And some important points here: these temperature things like low temperature, dark nail polish, or darker skin pigmentation can cause less reliable measurements. Ambient light, so if somebody's having trouble getting a good measurement, sometimes covering the device and the finger with something to block ambient light may get you a better reading. And then I wrote carbon monoxide poisoning, things like cyanide toxicity. These are two examples where standard pulse oximeters can't really tell the difference well. So just important to be thinking about. More cutting edge devices can actually tell the difference of that, but if that's something you're concerned about, you're not going to have reliable measurements on a standard pulse oximeter. But as a non-invasive measurement, it's very helpful for the outpatient setting to prevent you from perhaps needing to do a arterial blood gas, putting a needle into the artery, taking a blood sample, and then testing how much oxygen and carbon dioxide is in that blood sample. Low oxygen saturation or hypoxemia, low oxygen in the blood, is typically around 90%, under 90%. And you might see this at high altitudes where there's lower environmental oxygen, sometimes with primary heart or lung issues, again, making it hard to get oxygen across the lung membranes into the blood sufficiently. And then congenital heart abnormalities. Again, hopefully you would know about this, prior to taking care of this patient. But the idea of right to left shunting, meaning deoxygenated blood getting sort of recirculated. I just want this to be something that you've heard of. You certainly don't need to be an expert on this. And then hypoventilation from things like drugs, not getting a sufficient amount of respiration from like an opioid overdose, and insufficient respirations may cause that blood oxygen level to decrease. Now, there's no standard definitive blood oxygen level at which low oxygen or hypoxia of the tissues occurs, because it's very multifactorial. There's a lot of other physiology happening at the same time. But suffice it to say that somewhere around 90% would be pretty concerning. And certainly under 85%, this is someone who you should be escalating care for. So, putting this into practice, important to think about the context, associated signs and symptoms, and the trends of the vital signs. As far as the context, the situation, was there a preceding injury or illness or exercise? What have they eaten and drank? Are there any medications or chronic underlying conditions medically that you should know about for how to interpret that value? For example, somebody who normally has high blood pressure and comes in with low blood pressure, it's fairly concerning, as opposed to somebody who typically has low blood pressure and has the same low blood pressure. The constellation of findings in conjunction with other vital signs can also be helpful. For example, someone who's tachycardic with normal blood pressure or normotension, and somebody who's tachycardic with hypotension. The person who is, for example, losing blood and their heart rate is increasing to compensate and they're maintaining a normal blood pressure is fairly reassuring, as opposed to somebody who is increasing their heart rate but they're still hypotensive. They're not able to mount a sufficient blood pressure with the compensatory mechanisms. That's somebody who maybe I'm more worried that they're decompensating fast and not able to maintain their cardiac output. In the second case here, a febrile patient who is tachycardic versus an afebrile patient who's tachycardic. If somebody looks like they have an upper respiratory infection and they have a bit of a fever, and they have some tachycardia, then it seems to be very fitting with the infection and the elevated temperature, as opposed to somebody who's afebrile and tachycardic, and maybe they have a recent history of a surgery and they're on hormonal contraceptives and they were immobilized for a long time. And I'm thinking that this person might be someone who has a pulmonary embolism. And then in the third example here, somebody who's hypoxemic and bradypneic, breathing slowly, as opposed to somebody who's hypoxemic and tachypneic, breathing very quickly. The person who had an opioid overdose and is not getting sufficient amount of respiration, their blood oxygen levels are consequently falling. Whereas somebody who maybe has a primary lung issue and they are experiencing a significant asthma exacerbation, they might have low blood oxygen levels because they're not getting sufficient oxygen, and then they are tachypneic and they're breathing faster because they're having trouble getting sufficient oxygen. The important signs and symptoms to correlate here, there's certainly several of them, but in particular, I'll highlight perfusion, things like cyanosis, bluish, coloring of the skin, delayed capillary refill greater than 3 seconds, signs that this person might not be getting sufficient perfusion and blood flow. Someone who's distressed, diaphoretic, they're profusely sweating, tripod positioning, they look like they're using their accessory muscles to try to get a deeper breath. The level of consciousness, is this someone who's alert, or are they having waning consciousness? These are all things to be thinking about in conjunction with abnormal vital signs. Symptoms that would be of concern, things like dizziness, confusion, sensation that you're going to pass out, or pre-syncope. Is there any associated pain, like in the chest? Is there headache? Is there bleeding? These would all be things to be thinking about in relation to your abnormal vitals, to tell you, are they getting sufficient blood flow to their brain? Perhaps somebody who is feeling dizzy and having some altered mental status, maybe they're not getting enough oxygenated blood to their brain, and it's causing these symptoms. Whereas somebody who is asymptomatically having low heart rates and low blood pressure, maybe they're a well-trained athlete and that's where they live, and they're able to successfully perfuse all their important organs at those lower levels. So it's important to assess for symptoms. And then thinking about trends, are the vitals getting better, worse, or the same over a particular time period, as you're assessing maybe a few times over that time period. And then looking to reassess after you do interventions and think about, did the patient respond appropriately? Somebody who I think is dehydrated or has low blood volume causing their lower blood pressures, and I fluid resuscitate them, did they have improvement of their blood pressure? If somebody is hypoxemic and I give them supplementary oxygen, did the oxygen improve? And if it didn't, then I need to refine my diagnostic pathways to think about what else might be going on. And again, this might help think about how urgently they need to get to a higher level of care. And so hopefully that was a helpful introduction. Please feel free to send me an email at the bottom there, ctr_mcohen@salemstate.edu. I'm happy to answer any questions leading up to our in-person lab, where we're going to work on some cases and try to put this into practice a bit more. And I appreciate the time. Thanks for letting me be part of this course, and I look forward to working with you all. Take care.